get started, and we'll have some people who will come in and join us with the way we think the roads are pretty bad out here. So I just want to mention this is our first talk in our series this year for the Initiative for Individuals with Intellectual and Developmental Disabilities. This is our third year of the initiative, so we're excited about this. And our major goals are to support our graduate students in clinical psychology who plan to work with individuals with disabilities. We also want to eventually support research on disabilities and try to make life better with individuals. And we want to educate SBU in our larger community, and that's why we're doing these series of talks, to get the word out, information that might be helpful for families, for educators, and clinicians working with children, adolescents, and adults. And we also are trying to do this in a lifespan kind of with a perspective, so that we're talking about early development into the transition to adulthood. We had a speaker last year, Gary Stillwell, who talked about the transition to adulthood, and we plan to keep doing this sort of thing. So we want to get discussions going. We want to be a catalyst in the community to talk about these issues, and we hope in the spring of this year to have our first family kind of board or discussion group where we have families from SPU and maybe outside SPU sort of talking about issues that they're dealing with and things that they wish researchers and educators knew, so that we could do a better job. So today we're here and we're delighted that we have Dr. Maida Chen. And Dr. Chen is the director of the Sleep Center at Seattle Children's. She's assistant professor in the Department of Pediatrics at the University School of Medicine. She got her MD at Northwest University and did a pediatrics residency at Rush Presbyterian St. Luke's Medical Center. And she's going to talk to us today about her work, really clinical work and research in sleep, and especially sleep issues with children with disabilities. Thank you. I'll put this up.
I haven't done anything yet, so, except I did manage to get lost on the way over here. Okay. So just a little background on myself. I'm a pediatrician by training, and so this talk is largely going to focus on children. And I am used to thinking of it really in children with special needs. And those special needs can amount to a variety of things, but really children who demand special services, a large proportion of them do have intellectual and developmental disabilities, which is why this overlap seemed like such a natural fit. I don't have any disclosures. And really, just to start framing all of this, there's a general belief in society by parents, psychologists, anybody, that if a child got an ideal amount and quality of sleep, that we would maximize their developmental potential and we would optimize their overall health. Certainly, any parent in the room will tell you that their child's sleep is really sort of the holy grail the first year of life, and it continues to be on into later childhood and adolescence. But if we get children who are well slept, we end up with happy, well-developing, healthy children. But what happens when a child does not get that ideal amount or quality of sleep? So I think of it in sort of this framework where you have an outcome that's measured certainly in terms of ability, with increasing ability on the upward trajectory, and over time you have a child's natural trajectory, which is one that their ability gets better with time. That's their normal developmental trajectory. If you expose that child to a sleep disturbance, and I'm just talking sleep disturbance in a very generic way right now, and then at some point initiate treatment for it. The question is does that child then end up recovering his or her natural trajectory? Do we get a delay, or do they take a permanent deficit? And I think when we think of it in this way, then we start really thinking, well, how aggressive do we need to be in terms of assessing and identification of those sleep disturbances? How aggressive do we need to be about initiating treatment? And certainly, how are we going to be measuring the recovery, delay, or deficit outcomes? So what I'd like to talk about today, we need to talk about some basics first, the basic physiology of sleep, and I really hope not to bore anybody in here, but sleep is something that all of us do, and so hopefully it'll hit home with all of us. I'd like us to talk about assessment of sleep and its disturbances. These areas are going to be primarily in a typically developing child. The second part of it is going to be talking about the sequelae of sleep disturbances or a sleep disorder. And I'm going to be using sleep disordered breathing as a model of it because that's what we know most in pediatrics, and what it does is it allows us to use sort of a model of a naturally occurring disease and know what the outcomes are when associated with that as well as treatment. And then I'm going to talk about sleep disorders in children with special needs. I'm going to focus a little bit on FASD, fetal alcohol spectrum disorders, where I've done some research, autism spectrum disorders, and ADHD. And I actually think they're not in that order, so I apologize for that. And then through all of this, what I'd really like to do is just really, it's a call for good sleep health. It's a call for advocacy for both parents, providers, and the community at large, because sleep health and good sleep health really is so very important in the overall neurodevelopmental outcome for our children. So, sleep physiology. I could go over this, and I'm not going to. I probably knew a tenth of this for my boards, and then I passed my boards, and then I said I'm done with that. The point of this is that sleep is an incredibly complex mechanism. This is not something where you fall asleep in one fell swoop and you wake up in one fell swoop and that nothing happens in between, but there are any innumerable amount of things that happen to both put us to sleep, maintain sleep, and help us wake up. Normal sleep stages in children, let's just focus on this group here. We spend about 20% of our time, and children also includes adults to varying degrees, rapid eye movement sleep, or REM sleep, which is when people classically think of dreaming, and we spend about 20% of the night doing that. Non-REM sleep, which is further divided into 1, 2, and 3, and about 75%, and wake, which is actually, and this is in a well-slept child, they'll spend about 5% of the night awake. So when people say my child is awake a lot during the night, you sort of have to say, well, is that really an abnormality? This is the sequence of states and stages of sleep on a typical night, where we all fall into a fairly deep, what's called delta sleep, or a non-REM sleep at the beginning, and then we spend the night cycling between REM and non-REM cycles. We have about 5 REM cycles throughout the night, and we have a cluster of REM in the early morning hours, which is why the majority of us tend to wake up in a dream, or having your alarm clock incorporated into your dream or something like that. And that's a phenomenon most people know. And you also all know that if somebody tries to wake you up and you're not necessarily in a REM sleep, and perhaps in one of these deeper stages, it's really hard to get them motivated and moving. Stage 1 sleep is the light transitional sleep. It's less than 5% of our total sleep time, and this is when you have those classic slow rolling eye movements where you honestly feel like your eyelids are getting heavy. You're sitting in the back of the classroom and you're going like this, and you swear your eyes are open and you're looking at the lecture and you're like, I know, I can just do this. I'm just going to close my eyes for a little bit. And then you do that, and you've fallen asleep during that time. Or, God forbid, you're actually at a red light and you're like, I'm so tired, I'm just gonna close my eyes for a millisecond. And next thing you know, the person behind you is honking, saying, hey, the light's been green, move. You've actually fallen asleep during that time. That's stage 1 sleep. You do incorporate some cues from the environment, which is why you can hear the lecturer speak, you can hear the car honk behind you. Stage 2 sleep is what I call filler sleep, and that's really something that is characteristic on an EEG, which is there for sort of your illustration. That's the majority of our non-REM sleep. And then the last stage of non-REM sleep is stage 3 sleep. This is what we as sleep specialists refer to as deep sleep. This sleep is what we consider sort of the deep restorative sleep that happens when you have a lot of physical activity. If you go out and run a marathon that night, you have more stage 3 sleep. This is the kind of sleep that usually occurs at the beginning of the night, where you can't wake the person up. They incorporate minimal cues from the environment. This is where you don't hear the phone ring. You fall asleep in a really funky position watching TV, and your head is all cranked like this, and really no normal person would choose to fall asleep in a position like this, yet you can do it in that sleep because you are not incorporating any cues from your environment. If you're a parent, or take care of young children, you know that really deep sleep at the beginning of the night, you know you have a couple of protected hours before your toddler wakes up looking for you. This is where the toddler will fall asleep in the car on the way home from the dinner party, and you can schlep that toddler up from the car to their bed, and they're total dead weight. They have no cues from the environment. Versus REM sleep, this is dream sleep. During REM sleep, which is about 20% of the night, we have active minds. We dream for the most part during this time. It's not the only time you dream, but this is where classically most dream recall occurs. You do incorporate environmental input. If in your dream you are chasing a bunny and I measure your heart rate during that time, your heart rate's a little bit high. because your mind thinks it's running. But thank goodness your body is actually paralyzed during this time, because you don't want to be actually chasing bunnies in your dreams and running around your bedroom. So your body is actually paralyzed during that time. It has very low muscle tone. If you have a child who has a developmental disability that involves low tone, that kid's tone is going to go just completely bottom out during certain phases of dream sleep. Breathing is very irregular during this stage, and we do think that REM sleep has a role in learning and memory consolidation, but to be really honest, we don't know. There are certain medications that are used a lot in psychiatric practices that preferentially decrease the amount of REM sleep, that are incredibly effective as things like antidepressants. There's no medication out there that preferentially increases REM sleep per se. We do think, though, it has a role in learning and memory consolidation, and perhaps the strongest evidence for that is that infants will spend 40 to 50% of their nights in dream sleep, and they do proportionately a lot more learning than adults will, or even older children. And then, as I mentioned, you can be awake after the lights out time for about 5% of the night, and it's actually considered normal. What's the abnormal part really is if after a child has what we call a physiologic awakening, they signal to those around them that I'm awake and I need help going back to sleep. That is the abnormality, not necessarily that that child is having an awakening. Across the lifespan, as you can see, we spend more time in REM as an infant, and I have to be careful now because I used to say the older age, and I'm sort of approaching this end of things now. But as we age, the proportion of REM sleep goes down, such that in older adults it's closer to 13-14%, whereas you can see in a neonate it's about 50%. Sleep really is driven by two very active dynamic states. The first one is what we call process S, or sleep homeostasis. That is something very simple in the sense that the longer you don't sleep, the more you want to sleep. If you stay up for 48 straight hours, you have incredible process S drive. You just crave sleep. I mean, you just haven't slept that much, and you just, the more you are awake, the more you want to sleep. That's a very basic phenomenon. It's counteracted by something called process C, sorry that got cut off there, or the circadian process. And that's something that is really more clock driven. We will all, despite most of us wake up, let's say at 6, 7 o'clock in the morning, we all get a little bit sleepy around 2 in the afternoon. That's a natural circadian push for a little bit of a nap. However, most of us don't have the opportunity to nap. We stay awake until 10, 11 o'clock that night, but you are relatively more awake at 7 or 8 o'clock in the evening than you are at 2 or 3 in the afternoon. And that's basically this balance of process S and process C. The circadian clock is one that is something that is endogenous. It's a pacemaker. It has various physiologic functions. Perhaps the single most important contributor to it is actually light perception. So in a lot of our patient population that has developmental disabilities who may have cortical visual impairment, this is a huge problem. They don't get the normal cues. Their brain does not get the normal cues for a regular circadian rhythm, and we'll talk more about that. So that is my quick and dirty sort of basics physiology of sleep, and really for the purposes of this conversation, I think that's all you need to know. It is, textbooks worth of information, and it's fascinating in the sense that the study of sleep and sleep medicine, at least in the modernized world, is something that's actually relatively new. It sort of got more in vogue in the 1940s and 50s. So let's talk a little bit about how to assess sleep and its disturbances. In pediatrics, we sort of have the luxury that if a parent states, my kid has a sleep problem, well, there you go, there's the problem. That is the problem. By definition, that child has a sleep problem. It doesn't necessarily mean that that child's sleep problem is one that is diagnosable by a physician. It doesn't mean that it's going to have any abnormal test results, but it is something where the parental perception is such that there's a problem, and that needs to be, and that parents have identified it as a problem. And sleep problems, if you use that definition, of course, are going to be exceedingly common in childhood. 50 to 70% of parents said that their child typically experiences a sleep problem at least a few nights a week. And that's from the Sleep in America poll that is now fairly old data at 2004, but really this number has only gone up with time. The sad thing is that a parent doesn't necessarily offer that information unless asked. Only 10 to 25% of parents will actually consult a physician about a child's sleep problem. And sadly, from a provider standpoint, pediatricians don't ask, or at least they don't document it. About half of parents report that physicians don't ask about a sleep problem. 80% of parents report physicians not asking about snoring, which is actually an AAP, American Academy of Pediatrics guideline saying that you should ask about snoring at every single well-child visit. And less than, a 10th% of all pediatric visits are actually billed for an ICD-9 for a sleep code, even though it's clearly a very prevalent problem in the population. Every subspecialty has a way of categorizing its sleep problems. This is ours in terms of the Sleep Disorders International Classification. This gets a lot into nomenclature and semantics, so I tend to think of it more so in these sort of larger categories, which is amount, quality, and timing. Amount of sleep. Too much, too little, and that also includes if you have difficulty initiating and maintaining sleep, or as we all call it, insomnia. The examples I'm giving are actual ICD-9 codes, and the reason I put that up is because these are billable codes that certainly if you are a medical provider, you should be billing for. Insufficient sleep. If you have a teenager who's coming in and saying, well, I'm going to sleep at 3 o'clock in the morning because I'm Facebooking until then, but high school starts at 7 and I need to be on the bus at 5:45, guess what? I'm sleeping 3.5 hours a night. There's your problem. That's insufficient sleep syndrome. That's an actual diagnosis. Insomnia, persistent disorder of initiating or maintaining sleep. Then we have quality of sleep, nighttime observations of sleep. This is inherently difficult because most of us do not sleep with our children. And if you are sleeping with your child, you're hopefully asleep for part of that time and so unable to provide real accurate descriptions. So we are very dependent on daytime observations of perceived sequelae of poor sleep, and that's where we run into problems because people tend to think that a child who has poor quality sleep should act sleepy the next day when in fact they don't. An example of poor quality sleep would be sleep-disordered breathing or obstructive sleep apnea, which I'll talk a lot more about. And then timing. Timing is basically, the timing of sleep is alignment with society. School, family, work, that kind of thing. 100, 200 years ago, we didn't all go to sleep at 11 o'clock and we didn't all wake up at 6 o'clock and school didn't start at 7 o'clock in the morning. People have different hair color, different heights, different weights. They have different inherent sleep schedules. Society has not allowed that to progress naturally, and so that you may have somebody who is incredibly dysfunctional during the day because they are forced to wake up at a time when their body clock states, it's nighttime, I need to sleep. But if they need to be up at 7 o'clock and are otherwise labeled as a truant for not going to school, well, you got a problem there. And I'm not saying one is right or one is wrong, but certainly there is a misalignment of that clock. In terms of approach to actual sleep problems, there's all sorts of ways you can do it, and there are all sorts of acronyms and tables and lists of ways to think about it. Here's a little acronym called the Bears Questionnaire, which is talking about bedtime problems, excessive daytime sleepiness or dysfunction. Do they wake up after they go to sleep? What's the routine? Snoring and sleep-disordered breathing. That to me is not very intuitive, but it is the one that is most validated out there. What I do in sleep clinic, and I have the luxury of being able to do this with time, is I sit and I start at dinner time and I say, tell me about dinner, tell me what happens after dinner, tell me about the nighttime, going into sleep, everything that happens during sleep, what happens the next day, and what happens in school the next day. And I talk about weekdays as well as weekends. And I have the luxury of doing that, and you can see a pediatrician who is seeing somebody for a well child check in a 20-minute visit isn't going to have the time to do that necessarily. I think there are some important considerations in pediatric sleep assessments, and this includes those with intellectual and developmental disabilities because they are even more so reliant on observations and those people reporting those observations in a clinical setting. So 1, a parent may not be an accurate or knowledgeable historian. If you have these are sort of just Google pictures, but really, this person is going to say he has a major sleep problem. He's going to say, I have no problems at all. Here, certainly, if the mom is so tired but says that, I sleep with my kid every night, I know what he does. No, she really doesn't. And that's okay. That's what we expect. But it becomes inherent that if you are coming in with a complaint, my child doesn't sleep well, and really all you're doing is watching your kid at 5 minutes, for 5 minutes at 11 p.m. before you go to bed, you can see that's not a whole night's picture. The second thing is that fatigue does not equal sleepiness. Fatigue is a behavioral state, and sleepiness is a physiologic state. And there is overlap between the two, but sleepiness is your propensity to fall asleep. And usually in a pathologic state, it's usually in the wrong kind of setting. Fatigue is a behavioral state where you feel tired, but it doesn't necessarily mean that you'd fall asleep. The last thing is that daytime sleepiness in children rarely is this overt sleepiness. And when I mean children, I mean primarily prepubertal children. They have poor academic performance, they have more inattention, they have more hyperactivity and impulsivity, they have more mood and emotional ability, and they are almost never sleepy. If you have a child who's pre-pubertal and is coming in and that parent or teacher is saying, my kid's falling asleep in class, somebody's way over the edge. It's really, somebody's missed the boat. But this is usually how children, and this goes for typical and we think children with special needs, in the sense that if you take a totally healthy, intellectually not challenged person and you make them stay up at nighttime, they're kind of disastrous the next day. Just think about what happens to you the next day if you haven't slept well the night before, or God forbid you haven't slept well for several nights in a row. You're pretty dysfunctional. As an adult, your primary manifestation is going to be sleepiness, and you can medicate that with caffeine. Honestly, that's what the world does. That's what we all do. This is why Starbucks thrives. Children can't do that, or they do it, and it's called Ritalin. And that's why so many children are placed on Ritalin. I'm not even being facetious about this, but this is one reason why so many children are medicated without thorough workups. A lot of it has to do with sleep deprivation. How else can you approach a sleep problem? Well, questionnaires. People ask me about questionnaires all the time. Well, is there a questionnaire that I can just give out in my waiting room to see if I can pick up somebody with a sleep problem? The problem is that most pediatric sleep questionnaires have only been validated in research settings and have very little clinical application, because it doesn't matter what that parent fills out on the questionnaire. If that parent still thinks there's a sleep problem, there's still a sleep problem. So for the most part, questionnaires have been limited to research settings. I give examples of 2 here. I think there's actually only one more that's even been published that's been validated looking at general ped sleep. But they're there for your reference for any of the students in here who are looking for an outcome metric, and both of these at least have fairly good, I wouldn't call it good, larger ends of normative data and to compare a special needs population to. Other things that we do are sleep diaries, and this is something that I think is highly underutilized and that even parents can do. And if anything, what I feel this is most useful for is it forces parents to observe and record. They basically shade the areas in where they're asleep or think they're asleep with arrows using when they indicate they've actually gone to bed and woken up. It allows us to see naps, and we ask for little comments here. And oftentimes this can be diagnostic for circadian problems, insomnias, and insufficient sleep. So this is somebody who's a teenager who you can see tries, really tries to go to bed when mom tells him to go to bed at 10 p.m. and honest to God just cannot go to sleep until 12, 1 o'clock in the morning. And you can see on weekends this gets pushed out to 2, 3 o'clock, and this kid is sleeping way until the afternoon, and then tries to go to bed early again, a little bit earlier before Monday for school, and really can't do it. And so what happens? They end up crashing at 7, taking little cat naps at 7 and 9, and then you wonder why this kid also can't go back to sleep any earlier that night. This is classic for our teenagers. This is very common. This is somebody who is blind, and she has what we call a free-running circadian rhythm, in the sense that she has no consolidated periods of sleep. It just marches forward a little bit every day. Whereas, one day she'll go to sleep at 6, the next day 7, the next day 8, and it's something where you can imagine taking care of this child becomes a huge challenge for her family, because they cannot rely on when she would go to bed. We gave her a little melatonin, and you can see it's still all over the map, but there's a little bit more of some consolidation during what we would consider socially acceptable nighttime hours between 10 p.m. and 8 a.m. Sometimes it's really very simple. We had a kid come in, a 5-year-old typically developing, who stated that she had nights where she just honestly couldn't go to sleep, and this was one of those nights. And look at what she was having that night, and she was getting it as a reward basically for doing well in school that day. And can I just tell you, a special dark Hershey's bar has basically a shot of espresso in it worth of caffeine. And so we took out the Hershey's bar, and look, those little sporadic nighttime awakenings gone away. But parents had never put that together. And this is a lovely, perfect example, but it is something where, let's say if you have somebody who perhaps isn't as good as communicating those things and parents really have no idea what's up or down, and this kid maybe has gotten a little bit of chocolate or has gotten a little bit of a Coke as a reward or something because parents have over time sort of given into this concept of, here's a special treat. And what if that's the thing keeping them up? I mean, so these diaries are great in terms of keeping track of those things. Another non-invasive tool we use is something called actigraphy. It literally looks like my watch here. It's probably as small in profile. And basically what it does is it measures motion. This is something that's a fairly inexpensive way to get a gauge, a little bit more objective gauge than a diary in terms of when that person is asleep or awake. In a research setting, it has a good correlation with a sleep diary, but it's a little bit less so in real life. And basically, lack of actigraphy motion, which is the black lines, and we've highlighted here in blue, assumes that they're asleep during that time. So the red line is 8 p.m. and 6 a.m. This is somebody with insomnia whose sleep patterns are very erratic. This is somebody who's a shift worker who was a nurse actually, and 4 nights in a row, did 3 shifts where she was awake and then had to go back to sleep. And you can imagine this sort of wreaks havoc on your body after a while. Shift workers definitely have evidence of more medical problems because of what we presume to be circadian dysregulation. And this is an actigraphy of, again, somebody who is blind, and you can see it just sort of in terms of, if you assume that the less active areas are consistent with sleep, his sleep is all over the map and his action is all over the map, and it's again probably because of lack of a circadian rhythm. Other diagnostic tests, a sleep study. A sleep study is a thing that is considered the gold standard in pediatrics right now for sleep disordered breathing in particular. And what a sleep study looks at is brain activity, breathing activity, and body motion during sleep. It's objective testing. Insurance does cover it. People oftentimes wig out and say, oh my gosh, you're gonna hook my kid up in a singed lab setting. And I gotta tell you, this is my lab. It looks like a hotel. This is the bed that the kid sleeps in. It's a Murphy bed. During the daytime, we flip these up and we have clinic in these rooms. If the bed is big enough for a parent and a child to sleep in it, if that's what they're used to. We don't mandate that they sleep alone if they're not used to it. We have cribs. We have highly uncomfortable parent cots in the room. I'll tell you, most parents move to the bed halfway through the night because they can't handle the cots. We have little kitchen areas. We have, of course, all sorts of electronic distractions for the children, which I don't pretend to condone on a normal basis, but we do it for distraction purposes to hook them up. These are all, of course, pre-programmed with children's approved programming, so it's not live cable, I gotta tell you. It's like Caillou. It's oftentimes a huge disappointment to the kids. And then we also have parent rooms. So for the older children, or for parents who simply don't sleep with their children on a regular basis, we actually have pop-up parent rooms so that the parents can get a good night's sleep as well. And what do we actually monitor? This was a great cartoon that I found. But we look at brain activity, we look at eye movements, we look at muscle tone, we look at their heart, we look at air coming in and out, we monitor for snoring, we monitor their oxygen and carbon dioxide, we monitor their chest and tummy, and then we video record the whole thing. And people are always like, how do you expect my child to sleep with all that stuff on? And I gotta tell you, one of the big advantages of working at a pediatric specific lab is that our technicians are fabulous. We have a very, very low fail rate. We do about 1,700 sleep studies a year, and I would say less than 10 actually don't tolerate the testing. And those 10 uniformly have autism or trisomy 21. But even the most behaviorally challenging of kids, we can get the information on in terms of sleep disordered breathing. This is what the kids look like. These are not paid volunteers. In fact, they're paying us to do it. That's the funny thing. So this is a slightly older child. I want to say he was about 9. This is a 5-year-old. And this is unbelievably a 2.5-year-old who really can get to the point of tolerating it all. This thing that goes up their nose, that's the thing they uniformly hate the most. And little babies, we can actually place that after they go to sleep. But the rest of it, as you can see, our techs are great. They're so good at approaching it. We're going off on spaceships, we're searching for Nemo, we're doing any number of things. And really, from a behavioral standpoint, the kids do great. Parents are actually the ones who have a little bit more difficulty with it. We even can do babies. These babies were actually all babies from a study that I did looking at infants with prenatal alcohol exposure. I will not tell you which ones were exposed or not, but I can tell you that all of them did great with the study, and there are a mix of controls and subjects in here. And it's even okay if they do that. So this is my daughter. She was the first control for this study. We had to get special IRB approval for her. But I gotta tell you, she was the worst behaved one out of the whole lot of them. And she cried the hardest. She hated me the most. I made my husband stay that night. And I put this picture up there because we got perfectly good data on her after she fell asleep. It is something that, remember I said this is the thing they hate the most. We just put it on her after she fell asleep, and we got perfectly usable data on her. And this is her the next morning. I also show this because it's reminiscent of that scene from What About Mary, or that movie where, that's what they sort of look like the next morning. And I tell the parents that so that they're not wigging out. We do have showers on site so that nobody has an excuse not to go to school or work the next day, and it comes out with baby shampoo just fine. And this is what the sleep study looks like. This is a 2-minute window. We study them for at least 8 hours, so there's a lot of data we look at. It's okay if it looks to you like a bunch of squiggles. When I get tired, it looks like a bunch of squiggles to me too. But basically, we look at essentially their brain activity, their breathing activity. We look at their oxygen saturations, heart rate, and basically through all of this, we can count the number of brain, body, and breathing disturbances they have per hour of sleep. So even if you go and you sleep for 4 hours versus somebody who goes and sleeps for 8 hours, we are able to sort of normalize that data so that we can compare apples to apples between children. There are fairly robust normative sleep study data on school-age kids that are typically developing. There is not a good robust data set on any special needs population in terms of sleep study stuff. There are small subsets in certain groups of kids like autism, like FASD, like ADHD, but it's not robust data. The last objective test we do is something called a multiple sleep latency test. This was designed really to evaluate for narcolepsy. What it is that you have a series of 4 to 5 20-minute nap opportunities at every 2-hour interval. So you stay overnight for a sleep study. The next day, starting at 8 a.m., we say, lie down, close your eyes, go to sleep. And we count how long it takes you to go to sleep every 2 hours. Most people think that sounds like heaven, my gosh. You know, like everybody's like, oh, I could fall asleep during all of them. You actually can't. Most people can't fall asleep beyond that first nap. You might have a little bit of a dip during that natural afternoon siesta time, but most people can't fall asleep if given the opportunity to, unless they are really sleep deprived or they have a major sleep problem. And there are normative data, again, for typically developing prepubescent kids as well as adolescent kids. And it's abnormal if across all 5 naps you sleep in less than 8 minutes, or if you go into dream sleep during any of those episodes. So in terms of sleep assessments, just some take-home messages. Just know that sleep is a complex physiologic process. Asking one question about sleep is unlikely to give you a real full picture of what's going on, but ask about it. Don't rule out a sleep problem if they aren't sleepy, knowing that the manifestations of sleepiness in children are way different than they are in adults. Get sleep diaries. Sleep diaries force people to be objective and record what's going on, and have a low threshold for obtaining objective testing if you're in a place that actually can offer that. And I don't necessarily mean a sleep study, but even something like actigraphy is going to give you more information than just parental report. Parents learn from providers and children learn from parents. And if adult role models emphasize sleep habits and sleep health, that prompts parents and caregivers to think, assess, and awareness increases. So just ask about it. That's all really. If you can just remember to ask about it more than anything else, and not make this assumption that it's okay to live in a 24/7 society. We were all designed to sleep. The most sleep-deprived people die earlier. If that doesn't send a message of some sort in terms of importance of sleep, I don't know what does. So let's move on to sequelae of sleep disorders. And again, I'm going to be using a model of sleep disordered breathing because this is a naturally occurring disorder that happens frequently in general pediatrics. Again, the information I'm going to share with you now is in typically developing children. We have no reason to think that some of this is not applicable to those with intellectual and developmental disabilities. And in fact, it may be even more impactful in that population. We just don't know. So just to give everybody a quick background on sleep disordered breathing, this is where you have basically collapse of your upper airway repeatedly throughout the night. It's not necessarily full collapse, but even partial obstruction. It results in gas exchange abnormalities, meaning that your oxygen levels drop and your carbon dioxide levels go up. cortical arousals leading to sleep fragmentation, meaning that your brain is waking up frequently. Maybe not to the point where you're aroused to say, hi mommy, hi daddy, but just little blips where you are disrupting yourself out of steady state sleep. And autonomic arousals leading to systemic fragmentation. Every time you have one of these, your heart rate goes up, your blood pressure goes up. Things like that happen on a microscopic level, and they're very quick, but it's not something that we think occurs in a natural state where you're not challenged with breathing. It's diagnosed by presenting symptoms night and day and a sleep study, and it's naturally occurring model of sleep fragmentation. So remember what I showed you before in terms of the squiggle. So now you have a kid who basically if this is airflow, air is not coming in and out of their nose and mouth, so that's what the flat line is. Their chest and abdomen is still going. Their oxygen saturations was started off at a fairly normal 96%, are then going down to 84%. To somebody who's not medical, those numbers may not mean anything. For somebody who is on my end of things, if you were walking into an emergency room, you weren't breathing, and your saturations were 84%, you'd pretty much have an ICU hurling down on you quickly. So that just gives you an idea of what this child is doing sort of repetitively throughout sleep. And this is not something necessarily that parents know what's going on. This is happening at 2 o'clock in the morning as she's entering dream sleep. And most parents really aren't looking at their kid at that point in time. And so this parent actually reported that their kid didn't have any sleep problems at all, but this kid was having major behavioral challenges during the day at school. So we took out her tonsils and adenoids, and lo and behold, she came off her ADHD medications. Anyway, there are 3 major subtypes of sleep disordered breathing. I go into this because children with developmental disabilities particularly, large groups of them will fall into each one of these categories. So classic or type 1, 3 to 6 year old who has big tonsils and adenoids. Take away a kid's inherent intellectual abilities. Large tonsils and adenoids occur fairly frequently in any child. And so if you have a child who's got intellectual disabilities, gosh, look at their tonsils and adenoids. It may be that simple. They're still prone to these sorts of things. They can have open mouth breathing. They may have adenoidal facies. They tend to be thin. They tend to be inattentive and hyperactive. If they're overtly sleepy, it's pretty severe. And just think about that. Really, who complains in kindergarten that their kid's been falling asleep in school versus the teenager? The teenager will fall asleep in school, but a kindergartner really shouldn't. They're the kids who are going, brrr, like at the end of the afternoon. 80 to 90% of these kids are cured with adenotonsillectomy. That's what TNA stands for. And they have clinically resolved sleep disordered breathing. Oftentimes sleep studies will still have mild residual abnormalities, but clinically they've improved so much that we sort of let it go. And certainly anecdotally from a clinical standpoint, we have kids who, some of them really severe intellectual impairment, with bad cerebral palsy, mental retardation, who have kissing tonsils. We take out their tonsils, and parents will tell you they are more attentive the next day. They sleep better at nighttime. They are easier to care for the next day. They are more responsive to their therapies the next day. And those are the things that are critically important, I think, to me as a clinician when I assess for a sleep problem. A large clump called type 2 is really the obese adolescent. And obesity is an epidemic that, of course, we all know is taking over this country and this country's kids. 50% of the clinic patients that I see have a BMI of greater than the 85th percentile, which means by definition they are overweight or obese. That goes for kids with intellectual and developmental disabilities as well. While we tend to think of those kids as having trouble with eating and gaining weight, a larger proportion of them now are coming in really obese. They tend to be sleepy and inattentive as opposed to hyper and distractible, and adenotonsillectomy is has less of a cure in them, although it may improve severity, and many will need to go on to use CPAP, which I'm not going to talk about today. But a lot of these studies have been heavily confounded by obesity. And then type 3 or syndromic, these are kids who have major craniofacial abnormalities or underlying tone issues in a lot of the more genetic conditions. This is a kid with Pierre-Robin syndrome, another one, an older one who also has craniofacial microsomia and oral atresia. This is a girl with Crouzon syndrome. These two are children with trisomy 21. These are all children who have intellectual and developmental disabilities, and they all have really severe obstructive sleep apnea. And so it's something that to me, you can't even begin to address some of their daytime issues and daytime failures at school or with therapies until you assess, well, gosh, are they sleeping okay at nighttime? I mean, to not be able to start your day with a full tank of gas is a little bit unfair for a lot of these kids. So some of the outcomes related to untreated obstructive sleep apnea. I'm going to sort of glance over these because it's a little bit less pertinent to this crowd, but certainly from a cardiovascular standpoint, obstructive sleep apnea will make your blood pressure high and sometimes to the point of being diagnosed with hypertension. It certainly leads to pulmonary hypertension and cardiac dysfunction. It may impair their overall growth, and so even obese kids will gain weight, unfortunately, after we treat their obstructive sleep apnea. But we hope that that's countered by the ability to do more activities of sleeping well. They certainly have lower quality of life. In children who are overweight, certainly the presence of obstructive sleep apnea may later contribute to things like diabetes. These are not things we're looking at long term, but we need to be. So if you have obstructive sleep apnea as a preteen and you suddenly become insulin resistant, gosh, is that kid going to be on insulin at the age of 25 with florid type 2 diabetes? I don't know. Systemic inflammation has been there, but what I really want to talk about is the behavioral and cognitive dysfunctions. A general overview we've touched on a little bit, but an increase in daytime sleepiness really equates to mood, behavior, attention, memory, and executive function deficits, period. This has been shown over and over and over again. And gosh, if this doesn't characterize a lot of the struggles that our children have in this population, I don't know what does. Those with pre-existing behavioral and cognitive problems also have higher rates of sleep-disordered breathing. There is probably diagnostic overlap. I am sure that and studies have shown that children, for example, if you take ADHD, up to a third of those children, if you treat obstructive sleep apnea, no longer have ADHD. That's the best cure rate we've got for ADHD right now. So this is a fabulous review paper by Dean Beebe, and it's a little bit older now, but many of the findings are still true. I'm just going to run through these. The red boxes are sort of the highlight take-home messages. Obviously, from a research standpoint for the grad students in the room, you need to read this paper in more detail. You can't just run with that. But there's a lot of good data in there. But sort of broad stroke take-home messages is that sleep-disordered breathing, looking at meta-analysis and looking at pooled effect sizes, had significant adverse effects on attention, hyperactivity and impulsivity, and externalizing behavior using just the CBCL. I don't say just the CBCL, but clearly there are a lot of other metrics out there that are more sophisticated and whatnot, but the CBCL is used by like everybody in almost every situation, and we would want something that broad stroke to be looked at, and it's true, the CBCL does pick up on these things in children with sleep problems. When you look at emotional lability and baseline moods, sleep-disordered breathing had an impact and more impact on emotional lability and a less impact on slightly worsened baseline moods. And that's what parents will tell you is not so much that they're depressed or grumpy, but more so it's just that they fly off the handle like that. They have no ability to cope with sort of day-to-day stressors. They have very little ability to adjust to changes in pattern and things like that. This one is always very striking, but those with sleep-disordered breathing routinely had about 10-point lower IQs. This has been something that's also been shown in infants in terms of Bailey scores, looking at children who have snoring at the between 0 and 6 months of age. When you look at their Baileys at 12 months of age, they score 10 points lower than non-snoring infant controls. And Baileys have a rough correlation with IQ later on. I know that's in and of itself a large leap of faith, but certainly this is something that is found in younger infants who snore as well. When you look at kids who have underlying behavioral and academic problems, so these are kids who have already been identified to have struggles in school. Those who are in the lowest 10% academically of their class in the first grade had 9 times higher prevalence of obstructive sleep apnea. 7th and 8th graders who had poor academic performance oftentimes had a much higher history of snoring between 2 and 6 years of age. It implies that there's a long-lasting effect of these things. And in children who have parent-reported high hyperactivity scales, they have 2 times the higher risk of habitual snoring and sleep-disordered breathing. So if you look at basically kids who struggle, there's much higher prevalence of sleep-disordered breathing. And if you take that cohort of first graders who are in the lowest 10th percentile, In the group that they took out their tonsils, and then the other control groups who either didn't undergo treatment or who were controls who were also in that lowest percentile, the only group that changed from first to second grade were the ones who had their tonsils and adenoids taken out, and their grade points went from 2.4 to 2.8. 2.4 to 2.8 isn't, it's not like going from a C average to an A plus average, I get that. But if there's nothing else that is helping these kids, I'll take a 2.4 to a 2.8. If you look at attention and sort of behavior scores using the TOVA, even the kids who didn't have overt ADHD improved after taking out their tonsils and adenoids for obstructive sleep apnea. So everybody's attention and behavior got a little bit better. So I've talked about a lot of the sequelae, and we all used to think that kids, you would take out their tonsils and adenoids and that they'd recover. I think that there's more evidence now that they may take a permanent delay or even a deficit long term, and it's sad, but we see it clinically that, you know, there's a child who come in who, you know, tonsils removed when they were 2 or 3, and now in 3rd and 4th grade is still really struggling academically. And you just sort of have to wonder, is that child now suffering some of the more permanent sequelae of months to years of snoring, sleep disruption, lower oxygen levels that didn't get diagnosed until a little later? And I don't know the answer to that. I don't know what the answer is in terms of more aggressive or earlier treatment. But in terms of sort of my take-home messages, sleep disordered breathing is associated with neurocognitive behavioral deficits that many children with intellectual and developmental disabilities struggle with, and they struggle with chronically. Does sleep disordered breathing worsen those underlying disabilities? Does treatment improve daytime function? I don't know. Those are two really important questions that we need to keep asking. Sleep disordered breathing is often underdiagnosed even in a typically developing population. We still see a huge referral bias coming into our clinic. The majority of people we study in clinic still have really wicked obstructive sleep apnea. We don't study that many normal kids. It just means that it's not on people's radar enough. And sleep disordered breathing is more prevalent in those with intellectual and developmental disabilities due to associated medical findings, which I'm going to talk about now. So let's talk about some children with special needs. I'm going to focus a little bit on these 3 groups. But in general, just to paint sort of some broad strokes, children with special needs oftentimes are seen as difficult in terms of assessment, and in terms of sleep problems, there is little to no evidence that's out there, particularly longitudinal evidence. Most evidence out there is cross-sectional, and it gets into all sorts of methodologic challenges in terms of, you know, one kid with ADHD does not equal another kid with ADHD does not equal another kid with ADHD, and so you have to sort of know where they're coming from. There are teratogenic ADHDs, there are mislabeled ADHDs, there are all sorts of things out there. But we do have case reports, and anecdotal experience suggests that the prevalence of sleep problems in this population is quite high. And we do know that the impact on family, caregivers, and the child is just huge. When you ask families who are in this population what they could wish for, a lot of them will come in and say, I just want a good night's sleep. If I could just sleep through the night, I could deal better the next day. And parents who oftentimes have kids like that who are good sleepers will just have fewer subjective complaints in terms of their kids' health, how they deal with them during the day, because they know they get some respite at nighttime. What are the predisposing conditions to sleep difficulties in these children? Number one, far and away, has nothing to do with their actual condition, but it's the behaviors in which they've grown up. A lot of these kids have poor sleep hygiene, parents have trouble with limit setting, and they develop sleep onset associations. For example, the child with autism who has grown accustomed to just having an iPad placed in front of him and her at all times. Well, that child has never been taught that it's okay to take that iPad away at nighttime before you go to sleep. And so when you try to do that, thinking that somehow that should be this built-in expectation, that child has a complete meltdown. Well, what did you really expect that child to know? The whole, you know, up until that point during the day, anytime he asked for something, he got an iPad in response. So why not, if I don't want to go to sleep, so I want my iPad, and suddenly the answer is no, and then parents get pushed by the child's behavioral outburst, and then they end up giving him the iPad anyway just to sort of smooth things over. That child has now sort of won the battle, and suddenly the iPad is the new constant, and it's the new expectation. That's the development of a sleep onset association. That can happen in a typically developing child or a not typically developing child. But kids at all levels are smart and they know how to manipulate their parents in that sense. Sleep hygiene. It's also not uncommon for children, let's say with severe cerebral palsy, who have very poor communication, to just plant a TV in front of their room. And it starts in the hospital, I'll be honest with this. Just plant them in front of a TV, have it going all the time because it keeps them company. They're not as lonely and things like that. There's a perception that if the TV is on in the room that they would somehow feel better about it. And really, then that child has learned to sleep with a TV on at all times. That's the only way they know how to sleep. But nobody's really looked at, we know in a typically developing kid, going to sleep with the TV on really messes with your sleep quality. Why wouldn't it do that in somebody with cerebral palsy? I don't know, nobody's looked at it. So in large, there are still a lot of just basic pediatric principles that go into what predisposes some of these kids to sleep problems. But then we get into the ones that are more inherent to this population. The biggest one is probably intellectual disability. Studies have been very inconsistent in the sense that it seems like the more severe the intellectual disability, the more it predicts the presence of a sleep problem. That being said, kids on the far end of the spectrum who have incredibly severe intellectual disabilities oftentimes will sleep more and have so little response or interaction with their surroundings that the perception of sleep is actually a good one. The better predictor is likely poor communication, in the sense that if a child really has a difficult time communicating his or her needs or wants, sleep becomes more problematic, because when there is an arousal or before nighttime, they have difficulty communicating to their family what they want. Epilepsy is a risk factors. The seizures themselves, medications that we use to treat it, epilepsy likely disrupts melatonin secretion to some extent. Visual impairment, a lot of these children who have cortical visual impairment, as I was talking about earlier, they have disruptions of their circadian rhythm. They cannot entrain when they're supposed to be awake and when they're supposed to be asleep because they don't perceive light. Motor impairment. If you have difficulties positioning yourself at night, if you lay in one position too long and you're in pain, you're going to wake up. And if you can't have if you don't have the communication ability to then tell somebody, "My hip hurts, please turn me," your sleep is suddenly going to be disrupted. Upper airway obstruction is a huge component in terms of the motor impairment and secretion management. Sleep disordered breathing is likely a cause of, frankly, sudden death in this group. Spasticity and pain, those have huge impact on sleep quality, those with chronic pain alone, but certainly if you have underlying spasticity problems and you can't communicate those difficulties to those around you, you're probably not going to have great quality sleep. We take similar approaches because we don't have anything else right now, so we extrapolate from the typically developing literature. But you really need to keep in mind that the outcome metrics, like the ones I just presented to you, they need to be customized for the individual. It is unfair to expect somebody who can't communicate verbally to administer a verbal IQ test. It's just that simple. Goals of treatment largely in my clinical practice are to optimize that individual's health, function, and quality of life. That does not mean striving for a perfect sleep study, let's say. That really means to the point where the kid is not perceived to have breathing difficulties. Parents can function in terms of the caregivers, because if you don't protect the caregiver's sleep and their health, which is very much so impacted by their sleep, you're really not going to get very far. The prenatal alcohol example is one that I use because these kids oftentimes may look pretty normal, and depending on who assesses them, may not have, extremely overt intellectual disabilities or developmental disabilities, but they do have sleep problems. So you drink in pregnancy, 100% of those kids are infants who have prenatal alcohol exposure. A certain percentage of those kids will go on to have clinically diagnosed fetal alcohol spectrum disorder, and those children who are diagnosed with it then become adults with FASD. And we know children with FASD have sleep problems. We know they have daytime behavior and cognitive problems. We don't know if they feed into each other. We postulate that they do. And we don't know if treating one or the other will impact the other one. But unbelievably, the actual sleep problems in FASD have not been well studied. We don't know if it's an amount problem, a quality problem, or a timing problem, or sort of all the above. Everybody just said that children with FASD, they don't sleep, and it was a huge problem and a lot of medications being given for it. Let's just think theoretically in terms of the amount of sleep that these get. In terms of particularly insomnia and difficulty initiating and maintaining sleep, there is likely a role of parental and child anxiety. There is definitely a role of hyperactivity, and it's really a classic case of chicken or the egg. Are they hyperactive because they're not sleeping enough, or are they not sleeping enough and that's why they're more and more hyperactive during the day, and can they not shut their brains off, that kind of thing. A certain percentage of children with FASD have seizures, and some of them are subclinical ones, so are they seizing at nighttime? A lot of children with FASD also have, unfortunately, traumatic experiences early in life, and so are they having parasomnias or nightmares due to those traumatic experiences? And do they have primary neurologic toxic sort of disruption of normal forming neural circuitry, and that's why they can't chemically maintain sleep at nighttime? That's also a postulate. Or are they just programmed for shorter total sleep times? I don't know. Maybe children with in utero alcohol exposure simply are programmed to get less sleep. Breathing. It's a common problem in pediatrics, and we know what the outcomes of those are, which are problems which children with FASD tend to struggle with. But kids with FASD have two things. They have mid-face hypoplasia and poor tone. And these are things that really sort of predispose. Your airway starts here. If air has trouble getting into your nose, and we've all had colds where your nose is completely stuffed up and you really can't feel comfortable going to sleep at nighttime. Well, if your anatomic airway up here in your nose is really smushed, for lack of a better word, you may have trouble breathing, and that may certainly impact your sleep. We also don't know if they have things like movement disorders or restless leg syndrome at nighttime, if they have seizures or sleep fragmentation. Or do they have a body clock problem with a circadian disorder? This is a typical sort of illustration of delayed sleep phase, which is, so if society is in green, but this person's body clock is in orange, you can see that it may be perceived that they take a long time falling asleep at nighttime. They're hard to wake up in the morning. During those first few hours of school, they're biologically programmed to be sleeping, and yet they're expected to perform academically, or even drive. And you can see where then during those early evening hours when parents are trying to get them to bed, these kids are then perceived to be the most awake, and that's a problem. So what we did at Children's with Heather and then Judy Owens, who's one of the leaders of behavioral sleep in the country, we looked at a group of children with FASD and compared them to a large cohort of typically developing controls, and we used a standardized questionnaire and looked at sleep studies. And we basically were trying to characterize what these kids actually had in terms of sleep problems. Like, everybody said they had sleep problems. We didn't really know what that meant. And sort of the long and short of that study was that they really have pediatric insomnia, which to many in this room is not going to be news, but to the sleep medicine community, this was news. To the sleep medicine community, this was not on their radar necessarily. But 85% of these children scored above a cutoff on a standardized questionnaire in terms of having a clinically significant sleep problem. 85%, that's almost ubiquitous in this population. Yet it's nowhere part of the diagnostic criteria. There is no standardized guideline of care. And FASD is the most common preventable cause of intellectual disability in the United States right now. So to me, this has huge potential impact. If we can come up with a treatment for sleep disorders or their insomnia, standardize it and actually show efficacy, that is something that would be pretty much used almost every child diagnosed with FASD. People challenged us saying, how do you know it's not just ADHD? And we looked at those kids, we looked at that. We looked at the small percentage that didn't have a diagnosis of ADHD versus those who did, and they were no different. It was really presumably more of an alcohol effect as opposed to a label of ADHD. And then we looked at a subgroup of these kids, and we put them in the sleep lab because we wanted to objectively see what were their brains, body, and breathing doing during that time. And their bodies were fine, but their brains weren't. They woke up a lot. They had very fragmented sleep, and we couldn't figure out why. It looked like they were just sort of not able to maintain sleep for long periods of time, to the point where it actually decreased their total sleep time, so you have quality basically impacting amount. And they surprisingly had mild sleep disordered breathing. Their carbon dioxide levels were high, and they had a lot of snoring. I'm not sure how any of this is impacted. You know, I don't know where to necessarily go with this. The next steps for certainly a research setting would be to start insomnia treatment, start perhaps a trial of looking at medications that are known to decrease sleep fragmentation, things like that. But I don't really know how that's going to pan out. But you just have to think that if they struggle so much with these things during the day, whatever we can do to help them, and perhaps by optimizing better sleep, is worth the challenge. So when we talked to these families, though, pretty much all these families said it really started when they were infants. And so we then undertook a study where we looked at a small pilot study. We looked at 10 infants with prenatal alcohol exposure. And remember, these are infants too young to be diagnosed with FASD, that nobody would ever pick up. These were heavy-hitting using moms in the sense that we recruited them from treatment centers primarily. We had a hard time finding just alcohol users. Most of them were also concomitant drug users, but nevertheless, they had a very heavy alcohol exposure compared to, and we compared them to a group of controls that were pristine. They were planned pregnancies that had no alcohol at all documented throughout their pregnancy. It was difficult to recruit, but we managed to do it. And we wanted to basically see the differences between the two, and we wanted to be able to attribute some of those differences to things like alcohol use or drug use. And the infants with PAE compared to the non-alcohol exposed controls definitely on sleep study had difficulty maintaining sleep. They had sleep fragmentation just like the older kids. It affected the quality and the amount of the sleep, and they had much more profound sleep disordered breathing. They had surprisingly low oxygen levels during sleep. That's something that we all know. Oxygen levels are probably critically important to neural development. These infants had lower oxygen levels compared to control, and considerably lower oxygen levels. And these abnormalities parallel those found in older children with FASD. Makes me really think that there is something inherent to their neural circuitry that is established in utero, that we really need a better way of identifying as soon as they come out, because to be a baby with low oxygen levels, you can't go around testing every baby's oxygen levels when they sleep at nighttime. It's way too expensive, but we need a better way of figuring out who's at risk versus not. That's just one example. Another example are kids and adults with ADD or ADHD. I'm going to present primarily kid data here, but I'll say that there's been fascinating adult data looking at adults with ADHD or ADD and have found remarkably similar findings. So keep that in mind. The prevalence of ADHD in this country is about 8%. I don't even know what that means anymore because everybody has a various way of diagnosing. It's you know, really, there is not one diagnostic criteria for ADHD that everybody can really enforce and adhere to. If you take a population, though, who meets a DSM-4 criteria with ADHD, up to half of them will complain of sleep problems. Less than 50% of caregivers of those with ADHD, though, will report that they were ever asked about sleep problems by their pediatrician. The presence and impact of sleep problems in those with ADHD is probably most strongly driven by two things: comorbidities and medications. And that's been shown in several meta-analyses now, in the sense that those with these comorbidities are going to have markedly worsened sleep problems than those with ADHD who do not have these comorbidities. But these are very common comorbidities in ADHD. Up to 50% will have ODD. A majority will have conduct disorders. A sizable percentage, I want to say about 20-30%, will have mood disorders. Up to 50, and some studies will say up to 80% of kids with ADHD have some sort of anxiety difficulties, and that's going to punch you into a whole different category of sleep problems alone. But learning disorders and intellectual disability, these are all comorbidities that have been shown to have more of an impact on sleep disordered breathing than the diagnosis of ADHD alone. Medications is another huge part of it. And it's a two-pronged, really, response. There are some kids who have ADHD, you put them on stimulant medications and they can't sleep at nighttime. There's another group of kids who have a label of ADHD, who you put them on stimulant medications and by God, they finally sleep for the first time in their life. And so there is likely chemical differences between these two groups. There's probably genetic polymorphisms in terms of how they respond to things like amphetamines, and that's been shown in small groups that there are, you know, kids with ADHD who have certain genetic profiles that probably dictate how they metabolize and respond to things like methylphenidate, and those without that genetic polymorphism who don't have that same response. And so even within this cluster of kids diagnosed with ADHD, you don't have a predicted response. What they subjectively characterize the sleep complaints of is primarily insomnia, enuresis, believe it or not, or bedwetting, and primarily secondary bedwetting, meaning that they were dry for a period of time and then suddenly started bedwetting again, which not coincidentally is a common finding in obstructive sleep apnea as well. Parasomnias, nightmares, sleepwalking, sleep talking. Daytime sleepiness, especially in the morning, where parents will say they're hard to wake up out in the day. You know, oftentimes kids with ADHD are not considered to be sleepy during the day, but parents will usually report they're kind of hard to get going in the morning. And they wake up at nighttime. If you were to look on sleep study, what do we find? It's pretty varied. There is a huge overlap with restless leg syndrome or periodic limb movements. These kids kick a lot during the nighttime. It disrupts their sleep. If you poll a group who has ADHD, a little less than half were found to have restless leg syndrome symptoms. And if you look at kids who are just diagnosed with this, a quarter of them actually have ADHD or ADHD-like symptoms. So there is clearly a huge amount of overlap. And there are all sorts of case reports of kids who were diagnosed with ADHD, somebody diagnosed restless legs, treated their restless legs, and they were able to come off stimulant medications without problem at all. Same thing for sleep-disordered breathing. The percentages are a little bit less well-known and way more controversial than restless leg syndrome. It's about a third, in the sense that a third who have sleep-disordered breathing probably have significant ADHD-like symptoms, and a third who have ADHD as a diagnosis actually have obstructive sleep apnea. You treat their obstructive sleep apnea, the ADHD goes away. And like I said, a third cure rate with taking out their tonsils and adenoids of their of their ADHD. Medications don't have that kind of cure rate. That's just a misdiagnosis. If you look on actigraphy, they have more night-to-night variability, and if you look at that multiple sleep latency test, that test that looking for narcolepsy, kids with ADHD actually will sleep a lot more on those naps than control kids. So they're actually sleepy during the daytime. It's just that they're rarely given the opportunity or the right environment in which to actually go to sleep. We have kids with ADHD or a diagnosis of ADHD who come into the lab, and during these tests, we physically find them pinching themselves trying to stay awake for these tests because they really, really, really don't want to fall asleep, and they really, really, really are falling asleep. But they've been told that it's, they have managed to figure out how to stimulate themselves and do naughty things in school a lot of times in order to try to stay awake. Autism. The prevalence in autism is on the rise. It's at that right now. It's probably a little bit higher. As you all well know, nobody quite knows what the etiology behind this increased prevalence is. It's likely multifactorial, but certainly with it comes a whole host of sleep problems. So sleep complaints in autism spectrum disorders are very common, 44 to 83%. They complain primarily of insomnia. Initial, middle, and terminal, meaning that they have difficulty falling asleep, staying asleep, and they wake up early. The early morning wakenings, I will say, is probably one of the most challenging problems we encounter in sleep clinic because we really don't have good strategies, medications, or anything else for it. And it is the thing that parents seem to find most disruptive to their home life. There is a lot of evidence, though, that a lot of their insomnia may be behavioral in origin and have very little to do with their autism, in the sense that these kids, just like any other kid, has learned sleep onset associations. The whole iPad example I was giving before, it's common in autism these days. They tend to have very poor sleep hygiene, where parents will just say, please, 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 just don't disrupt me for a little bit while I do the dishes, make dinner, do whatever it is I need to do, and just watch TV. So that kid learns that, they get TV when they ask for something, they learn how to go to sleep with the TV on, nothing else changes. There is also evidence, though, that on a physiologic basis that they have irregular sleep-wake patterns, where if you look at their melatonin levels, they tend to have high melatonin levels during the day, so they're supposed to be high at night. They have low melatonins at nighttime. So in a certain population of kids with autism, giving them melatonin supplements at nighttime really helps both their daytime behavior and nighttime sleep. If you look on sleep studies in kids with autism are a challenge to obtain and tend not to reveal anything. So unlike the ADHD crew, these kids do not have overlap in terms of sleep disordered breathing or periodic limb movements. Like ADHD, the things that drive sleep problems in autism really have come out of the woodwork. It's the comorbidities. So anxiety is a big one. The prevalence of anxiety here is not in autism, but more so just in the general population. But once you fall into a category that somebody suspects anxiety, sleep problem prevalence goes through the roof. Insomnia, particularly in kids who are anxious, is very, very high, and I would say that anxiety is one of the more underdiagnosed things that I see in sleep clinic. But they have frequent awakenings, and it's not that they necessarily have frequent awakenings, it's just that they signal to people when they're awake, and so it's perceived as frequent. They don't want to go to bed, they want to sleep with somebody, they have nightmares, they have nocturnal fears. There's not really a whole lot that's found on sleep study other than it takes them longer to fall asleep and they have worse sleep efficiency. Depression is another comorbidity in autism and ADHD. The prevalence in the general population is 2 to 8%, and again, sleep complaints are very common in those with depressive disorders. Again, it's insomnia and early morning awakenings. Hypersomnia, and even in depressed children, is a little bit less common than it is in adults. There are some unique sleep findings in depression that we see on sleep study, but it's certainly not diagnostic. There is a phenomenon that's interesting in children who have insomnia of all sorts, that they have paradoxically good sleep studies that shows that they actually sleep quite a bit, but if you ask them the next morning, they say that they only slept for 2 hours and that their sleep quality was terrible, whereas I can show you on sleep study these kids did great. And so there are certainly ones out there with paradoxical perceptions, and that also is something that's a huge problem. Bipolar is a little bit less prevalent, but sleep complaints are almost universal in those with bipolar. And this is something that's going to be well known to this crowd in terms of decreased sleep needs during mania, with increased sleep needs or hypersomnia during some of the more depressed phases. Very few studies have been done. Oops, that should say bipolar and not MDD. Just sort of final thoughts in terms of sleep and special needs. We really don't know the trajectory of any of these things in children who have intellectual and developmental disabilities. We have some case reports, and we have specific disorders like ADHD and autism that have helped guide the way a little bit. The prenatal alcohol example in FASD has been a huge learning experience for those of us at Children's, just because this was a group of kids where sleep problems were the thing that parents complained about, yet no research was being done on it, and we were able to sort of finally bridge some of that clinical gap. But we really, as a community, and this is where my whole call to advocacy comes into play, as a community of both providers, parents, professionals caring for individuals who have intellectual and developmental disabilities, we need to prioritize inclusion of these special needs children in research studies that are designed for them with the appropriate outcome metrics in mind. Sleep problems in general pediatrics have good treatments. We should not be withholding these treatments and withholding diagnoses from these kids who may very well benefit from these treatments, which oftentimes are non-invasive and pretty easy to do. So, we're missing a piece of the puzzle here, and hopefully this will just call to all of us, let's just assess about it. We don't have great tools right now, I know that, but we're never going to figure out those tools if we don't see these kids more regularly, if we don't start to think about pilot studies and then ultimately well-designed studies looking at the role of sleep and sleep disorders in these children. So we went over these things, and I'm just going to leave this final sort of conclusion up there, which was my ultimate goal, which is just really a call to advocacy for good sleep health, both in typically and challenged populations. So I'm happy to take any questions if anybody has any. If not, you can contact me by email or anything else. So thank you very much for having me, though, tonight.
I think we have a couple.
Yeah.
And does one night in the sleep lab give enough information about?
Excellent question. So for sleep disordered breathing, which is the primary reason we'll do a sleep study, yes, it does. It has about a 95% ability to pick up a kid from night to night to night to night. Less than 5% of kids would actually be missed on night one if you were to do two back-to-back studies. So for the most part, if you have sleep disordered breathing, one night should find it. What one night is terrible at is things like sleep architecture, so how long it takes you to fall asleep, how many times you wake up. That is less easily judged on a one-night basis. Those sorts of studies really need to be done on a several-night basis where you need 2 or 3 nights to entrain to a sleep lab setting, and unfortunately the cost of these studies is so preclusive that's unlikely to happen. Yeah?
Has there been much research where children are receiving treatment, maybe specifically for trauma, and then following their sleep patterns after that?
Do you mean
Like behavioral health treatment for trauma?
oh, yeah, okay. So there is actually relatively little known about children who suffer trauma. There's probably more in the whole PTSD literature, but there is a large proportion of children who suffer physical trauma, who have either prolonged hospitalizations or a prolonged recovery. We actually know very little about their sleep afterwards. There's been very little research on that. There's been 1 or 2 papers looking at children who have had traumatic brain injury, and their sleep by actigraphy afterwards is a complete mess. It's all over the place. And parents will tell you that in the traumatic brain injury kids, sleep is a huge issue, and most of them are medicated sort of empirically for it, and it's all blamed on this brain injury thing model. We don't actually know. We don't actually know. Certainly in children who have nightmares associated with post-traumatic stress disorder, PTSD, treating those nightmares with something like prazosin improves their quality of sleep quite a bit. But that's a separate thing from sort of the physical trauma. Just even being in the hospital, there's no research on how disruptive, or very little research on how disruptive your sleep is after you've been in the hospital for a night or 2. Parents will tell you it's awful, but we don't actually know. Yeah?
So I'm curious, and you may not be able to answer this question, but given how important sleep is and how much of our time we spend in sleep, why are we not paying more attention to it? Like, why is it just now coming to the fore in terms of an area of research? Does that make sense?
Yeah, no, it makes total sense to me. I think a lot of it is societal in the sense that in the last probably 20 to 40 years, the advent of technology, the mandating of earlier and earlier school start times are 2 major things that have really pushed kids' sleep into this arena of being compressed. There's way more expectations compared to a generation ago, and particularly compared to 2 generations ago. You know, 2 generations ago, we weren't all doing 18 million activities after school. We didn't have before school activities, that kind of thing. We also didn't have electronics and things like that. You know, when the sun went down, you went to sleep because there was nothing else to do. You had one TV that was in the living room that got terrible reception when the wind blew. You know, so you didn't watch TV. And because of that, you did things that were more conducive to sleep. You sat in darker rooms listening to radio shows. You read books. You did things that were just a little bit more sedate. Instead, now we have kids who are playing video games all night long. It's not just the physical activity of the video game, but certainly there have been so many studies looking at sort of media exposure and right before bedtime, but that stuff really, really, really messes with your sleep quality, both initiation of it as well as the quality of it in terms of fragmentation. As young as preschool age, preschoolers who watch Thomas the Train for half an hour at 7 p.m. have more disrupted sleep than preschoolers who don't. Thomas is really, I mean, it's kind of benign, but it's a lot of visual imagery for a kid who's 2. And parents will oftentimes say, but nothing else zones my kid out and calms them down as much as watching TV and cartoons and SpongeBob and Mickey Mouse Clubhouse and stuff like that. And what it is they are so overwhelmed with the fast pace of the cartoons and all this visual imagery that's coming on, and you see the kids go like this. And they don't do anything. And they're just trying to process, and they can't. They're so overwhelmed with it. And so what I asked parents, I was like, okay, what happens when you turn the TV off? 99% of them will say the kid has a meltdown when I turn off the TV. So, does that really make you think it's a relaxing activity? If they were really relaxed beforehand, you should be able to turn it off and they should be able to stay relaxed, like a bath or something like that. But then what happens is that the kids have a meltdown when parents turn off TV, so what happens? They turn it back on. exactly. And so you just perpetuate. And so I think from just a pure anthropologic, standard, I think that's a lot of it. It's not just sleep duration. Sleep duration has always marched down with time. But now it's really sleep quality, because for the first time in history, we have things that are known to fragment, disrupt sleep terribly, that are standard in our 24/7 society. I mean, like I said, before it used to be you'd be lucky if you had one TV in the entire household. Now I think the average household has, like 4 or 5 TVs, and they're all in bedrooms, and they're all in kids' bedrooms. Because kids, we also live in a permissive parenting society where, parents are looked, or they feel like they're looked poorly upon if they can't provide that TV in the room. And how come your kid has DS and mine doesn't, so I'm going to get him a DS, that kind of thing. So I think there are a lot of truly fascinating things that go into it, but I think that's why it's come out more and more recently in certain years.
So it's more an artifact of society and in industrialization and other things, as opposed to something going on with our biology.
I think the big biologic challenge to all of this has been obesity. So obesity really, it's not just the breathing in obesity, but obesity probably does all sorts of things to our neuroendocrine systems that mess with sleep. So obesity is another huge contributor. That's like a whole, grand rounds in and of itself. But I would say that would be the big physiologic thing that's occurred, but I think more of it is societal. Go ahead. I saw a hand back up there, but I will get there in a second.
Has there been, have many studies looked at the cross-cultural or international differences?
Yeah, and so we are probably, there's only a handful of nations where the standard is to have your child sleep in a separate room. And so certainly if you go to third world countries, if you go to the Asian countries and things like that, the standard is co-sleeping. And parents have, what are those parental expectations or perceptions about sleep, or, sleep problems or not sleep problems. And so parents, like, for example, in places like Taiwan, China, Japan, will say that their children seem to have more sleep problems compared to American kids. And that's parental report, and a lot of that is because they sleep with their kids regularly. That's habit. But that when they get older, those sleep problems tend to disappear compared to ours. And the sleep problem rate parallels that of obesity. So in countries that have less of an obesity problem, you see less of an epidemic of sleep problems. And obesity is just a marker. I'm not trying to blame it on obesity, but I think it's a marker of some of the societal things that go on. Number of televisions per house associated with sleep problems. Is the TV actually causing inherent sleep problems? There's actually evidence that it does. But again, it's probably more of a marker of just the priorities in the household and everything else. Lower socioeconomic statuses across the world, not just in the US, have more common sleep problems that are reported. And not surprisingly, that also parallels obesity. So the long answer is that sleep problems across the world are increasing. America leads the charge in some ways, but it is actually something that, especially in the younger age groups, is more commonly reported actually in societies that routinely co-sleep. Yes?
My daughter started snoring at 3.
Mm-hmm.
It's been 4.5 years since. I've never talked to the pediatrician about it.
You should talk to her pediatrician about it. And it may have had no impact, it may have significant impact, but certainly you should let your pediatrician know about it and have somebody assess just in terms of what her sleep and sleep impact is on her overall health and development and everything else like that. But you should definitely talk to your pediatrician about it. Something that pediatricians are supposed to do, and as a group pediatricians are woeful at doing it, which is assessing sleep, but particularly snoring. They're supposed to ask about snoring at every single well child visit, and it does not happen. Yes?
By treatment there, I'm assuming you're talking about BiPAP, CPAP.
Taking out tonsils or adenoids, and that's...
Are there any, I have a son who is a CPAP user, or BiPAP user, and seeing this recovery delay deficit, it's like, oh gosh. But no, it's okay. I mean, it's good to know. Are there any new types of treatment coming down the pike that look promising, or?
For sleep disordered breathing in particular? It depends on It depends on why he needs the BiPAP. And I'm just going to step back and make gross generalizations and not about your child, obviously. But certainly, there are always new surgical things that are being pioneered to help, looking to help at the airway and things like that. Even compared to a couple of years ago, I think some newer, more recently trained surgeons are perhaps more savvy at looking at the airway and looking at the airway under conditions that would mimic sleep and see what degree of floppiness is there and things like that. These are not things that we could assess all that well even 3-5 years ago. So things like that. I think there's more. As your child gets older, I think there's more options in terms of things like oral appliances, which can help position the tongue and some of the muscles that go around. There are, believe it or not, there are little stickers, I don't know what else to call them, that actually go in the nose that have a little filter at the end that help to create a positive pressure inside the nose to help keep the nose open if the nose is the area that you're obstructing. There are definitely newer BiPAP and CPAP mask interfaces. What most people don't know is that every 5 years you're entitled to a new BiPAP machine, and the newer machines and the newer masks out there simply make it easier. But in terms of something that's been really overwhelmingly different, that's changed our trajectory, not terribly. I think it's important, though, in children who need BiPAP. A lot of kids who need BiPAP have tone issues and things like that, and we really don't have a strategy for that at this point in time. So it's rough, yeah. Okay. Yeah.
We're school nurses, and
Yeah.
we see this every day. And we call the doctor and say, these tonsils are kissing, the kid is falling dead asleep in the middle of an active, noisy classroom.
That's a problem.
And we can't get them to listen. How do we get them to listen? And with this medical situation we've got these days, people can't afford medical care for their kids.
Yeah.
They're not going to doctors like they used to, so they don't press the doctor either.
Yeah. Gosh, to answer that question, just, you know, we need to go 20 steps back and just sort of reprioritize in terms of what we mandate important or not important. So I think, first of all, if you guys see a kid, you know, as school nurses falling asleep in school or anything else like that, by God, that has to be reported to the physician. I think you can push the physician. I'm certainly happy to forward any articles that you can even forward to them and just be like, look, hello, look at the outcomes that is associated with this. You know,
To fight the insurance company.
you do. And I'm not the best person for that student to come see. That kid just honestly needs to go to an ear, nose, and throat surgeon, make a one-time pit stop, and get those things taken out. That is the most effective. It's cost efficient in the sense that it is a fairly safe surgery, and it's over a 90% cure rate, and you don't really need a diagnostic test if you have something like that. I think a lot of it is parental education as well, where parents seemingly seem to think a little less of their kids if they are unable to keep up with their peers. You know, be like, well, you know, Johnny only sleeps 6 hours a night and he doesn't fall asleep in school. Sort of, what's your problem? And that whole perception needs to be changed. I mean, we just culturally are living in a society where lack of sleep is rewarded as a good thing, and so that's something that needs to change. I don't have great strategies other than, you know, calling the pediatrician, making parents aware. I oftentimes prefer referral lists, you know, and just say, you know, call these ear, nose, and throat doctors, self-refer. You can do it now for a lot of insurances, and pediatricians oftentimes will get pushed into it if the parents know how to push them. So a lot of the onus, unfortunately, is on parents. I'm surprised, though, that the pediatricians are not listening to the school nurses. That's terrible.
And that one particular poor kid, he was even put on melatonin that his mother was taking by the pediatrician. Well, try your melatonin, give him the same dose you take and see if those. But he snored through the night so loud he kept the whole family awake, and they complained about it all the time. And could see his tonsils, but they were trying everything else without.
Gosh, that to me is almost tantamount to medical malpractice with the amount of data that's out there these days on stuff like that. I mean, the morbidity associated with untreated obstructive sleep apnea, I mean, I talked about the neurocognitive behavioral stuff, but I mean, there are some serious ones like heart failure and sudden death that I didn't talk about today. But, you know, in a kid who's that bad off, that's some serious risk. I mean, this is why middle-aged men who have untreated obstructive sleep apnea, that's why they don't wake up in the morning sometimes, like they die in their sleep. It's because of probably a sudden obstructive event. So there is a serious medical malpractice risk in there for not paying attention to something like that. Maybe you should tell the pediatrician that.
Bye-bye, Chen.
Yeah. Well,
Thank you so much.
oh, thank you.